other cases, if the baby's heart rate is still less than 100 beats per minute after ventilation corrective steps, to ensure adequate ventilation, we need to consider the last step in Mr. SOPA, alternative airway. In Chapter 3, we will introduce practices including endotracheal intubation, chest compression, and medications to help cope with deteriorating situations. Inserting a laryngeal mask or endotracheal tube should be considered if the baby's heart rate remains less than 100 BPM after the first 5 ventilation corrective steps. When the baby's heart rate remains less than 60 BPM, despite adequate ventilation for at least 30 seconds, it is strongly recommended to do the intubation and then start chest compression. Team members involved in the cure of newborns should know the basic insertion supplies and sizes to choose. The insertion operator should choose the corresponding sizes and depths according to different babies. For intubation, the insertion operator stands at the head side of the infant. The assistant stands at the left-hand side of the operator, prepares the stylet into the endotracheal tube for insertion, and puts it on the left-hand side of the operator. Another team member on the operator's right-hand side can help to maintain the baby's position throughout the procedure. During insertion, the operator should never have to look away. The steps of intubation should be completed within approximately 30 seconds. After the insertion, the assistant removes the stylet, connects the CO2 detector if available, and attaches the PPV device. The primary methods to confirm the intubation success are a rapidly increasing heart rate and exhaled CO2 detected. Other signs include audible and equal breath sounds near both axilli and symmetrical chest movement with each breath. There should be little or no air leak from the mouth and decreased or absent air entry over the stomach. This newborn had received an additional 30 seconds of ventilation, and the heart rate is still less than 60 BPM, so according to the algorithm, chest compressions are required. The compressor should be at the head of the infant, and the person providing PPV should be at the side. The oxygen concentration turned to 100%. Place the thumbs side by side or one on top of the other in the center of the sternum. The compression must be accompanied by ventilation. Each cycle of 3 compressions and 1 ventilation takes about 2 seconds. The compressor calls it out so that the person doing PPV can hear 1 and 2 and 3 and breathe, and when performing chest compressions, please notice that the heart rate from ECG or pulse ox will not be accurate. After 60 seconds of effective chest compressions and ventilation, briefly stop compressions and check the heart rate. If the baby's heart rate remains less than 60 beats per minute, then continue a second time of 60-second chest compressions, and meanwhile prepare medications including epinephrine at a concentration of 1 mg, 10 milliliters. For medication delivery, prepare for the umbilical venous catheterization, UVC. The provider usually should clean, tie, and cut the cord. After attaching the flush, the provider inserted an umbilical venous catheter 2 to 4 centimeters. During prolonged resuscitation, a skin temperature sensor for monitoring is necessary. The team member administers epinephrine at suggested dose of 0.2 milliliters per kilogram. After intravenous epinephrine, continue PPV and compressions using 100% oxygen. After 60 seconds, pause compressions and check the heart rate. If the heart rate is still less than 60 beats per minute, continue ventilation and compressions. Repeat the epinephrine dose every 3 to 5 minutes. If there is not a satisfactory response, consider other problems such as hypovolemia and tension pneumothorax. Medication like volume expander will be used for hypovolemic shock. For other interventions coping with special problems, please refer to Chapter 10 in the NRP 8th edition textbook. For more detailed guidance on intubation, UVC placement, and medication delivery, please reach the references listed below. After the steps, if the heart rate is rising, adjust the level of intervention according to the NRP algorithm. If the heart rate is still less than 60 beats per minute, check if all the possible measurements and interventions have been conducted appropriately. If the heart rate is not detectable after around 20 minutes of resuscitation, the decision to discontinue resuscitative efforts should be made individualized and include the family of the newborn.